Hi, I'm Dr. Padmaja Lokireddy. I'm a bone marrow transplant and cellular therapy consultant at Apollo Cancer Hospital, Hyderabad. Bone marrow transplant is a complex medical procedure where we collect the stem cells and give it to the patient after high doses of chemotherapy. If it is taken from the patient alone, it is called autologous transplant. If it is taken from the donor, it is called allogenic stem cell transplant. The donor can be their full match sibling or unrelated donor from the registry. Sometimes we cannot find a full match. At that time, we go for a half match options, which is the latest part of the bone marrow transplant. When we collect their bone marrows from the donor, we just not only collect stem cells, we also collect their immune system, that is T cells. And they actually help to protect the long-term cure of the cancer patients. But sometimes they can also give unwanted side effects. These T cells go and attack on the patient's normal healthy cells and cause reactions in different systems. This is called GVHD, that is graft versus host disease. There are plenty of ways we can reduce these side effects to get the best outcomes. Bone marrow transplants are done for different age groups, right from 1 year to 70 years. Bone marrow transplant is done for cancerous and non-cancerous conditions. The commonest cancers being multiple myeloma, lymphoma, and leukemia. Non-malignant or non-cancerous conditions commonly are thalassemia, aplastic anemia, a broad category of bone marrow failure syndromes, and immunodeficiency syndromes. When we collect these stem cells from the donor, especially in a half-match transplant, there are a lot of advancements have happened to reduce the side effect profile. When we collect the half-match, historically, when we started off in 2009, we used to collect bone marrow stem cells from the bone marrow, where the donor goes to the theatre an hour or two under anesthesia. We collect a liter of the donor's bone marrow, purify it, and give it to the patient after giving heavy doses of chemotherapy and radiotherapy. Now that has changed, and we hardly do these kind of procedures. We subject the donors to collect the cells peripherally without anesthesia as a daycare procedure, and it's become simplistic. But there are problems with this. We overcome these problems in a few group of patients by manipulating the graft. T cells are causing a problem. We remove a subset of T cells called alpha beta to reduce side effect profile of GVHD. This is a graft manipulation called alpha beta T cell depletion, which has changed the way we treat in a half match transplant for thalassemia and immunodeficiency syndromes. And when we do transplants, we get the best outcomes by choosing the right patient at the right time, giving the amount of chemotherapy, radiotherapy appropriate to the patient, and using the different conditioning regimens, manipulating the graft, and using the effective post-transplant strategies, we can get the best outcomes. Sometimes we also give radiation therapy to cure the cancers and also help to take over this graft by the patient. And we use a sophisticated radiation machines like tomotherapy in order to give total body irradiation or total lymphoid irradiation or total marrow irradiation. These new techniques will prevent side effect profile, that is toxicity on the different organs. But a small subset of patients cannot get cure from the bone marrow transplant, or the disease is not responding. In those patients, we use a CAR T cell therapy. This is chimeric receptor T cell therapy, where we collect the T cells from the patient and weaponize them, modulate them genetically in the laboratory and give it back to them. The way it is done is we collect the T cells as a daycare from the patient, send it to the laboratory where these T cells are activated, proliferated, transduced with a CAR gene. So these cells are modulated to know where the cancer cells are. And when they're given it back to the patient, they work effectively. Within a month, you're looking at responses to the treatment. We do this CAR T cell therapy for 3 different conditions broadly, that is lymphomas, acute lymphoblastic leukemia, B-type, and also multiple myeloma. With these effective strategies of advancements in transplant and CAR T cell therapy, we're able to cure most of the patients and give the best long-term outcomes without much morbidity. Thank you for listening.